So pedicle screw insertion technique, how to get it right 100% in first go. Is Siam the answer, the key role player? Believe me, when Siam shows you good AP and lateral view position of pedicle screws are good, even it can lead to breach on the anterior aspect or of the sacrum, just like shown in the CT image, which caused L5 radiculopathy in that case. So Siam is definitely not the answer. So what are my reliable friends for the technique? Anatomy is the foremost. The understanding the pedicle anatomy is the foremost reliable thing. You have to understand the anatomy of pedicle. It is a funnel shaped structure with a cancellous mouth, the cancellous footprint with a narrow waist or isthmus, and it opens into a receptive vertebral body. You have to understand the important relations of the pedicle, like just inferior lies the exiting nerve root and medial lies the thecal sac, and you should know how to visualize pedicle in the C-arm, like in a true AP view. The eye of the owl are the pedicles, and other structures you should locate, like how to see facets and the transverse process in the imaging. Whenever I do instrumentation in spine surgery, I always look preoperative imaging to help me, like the CT and MRI for pedicle width, for the medial angulation, is there any rotation in the vertebra, or to see facetal hypertrophy, which can make my entry point getting difficult. The patient position should be neutral. Try not to hypolordoz when you are instrumenting. Now the other most important thing is exposure. See, you don't see the pedicle when you are doing surgery from posterior aspect. You just imagine pedicle in relation to posterior structures. You should, while exposing the spine, you should see ideally up to tip of transverse process. You should clearly see the relation of pars, the connection between the pars, facet and the transverse process, and you should also see the spinous process alignment. Next part is how to locate my entry point. So as I told you that pedicle is the mouth of pedicle is cancellous, so you have to expose that mouth, you have to remove that cortical bone. Now several entry points are described, like mammillary process technique. At the junction of pars and TP, you will see a bulging part which is known as mammillary process. Just bite that process and make the entry point. Next is pars interarticularis technique. It is at the lateral, meeting a line along the lateral border of pars and middle of the TP, and the intersection technique, the lateral border of facet and the midline of TP. But whenever there is facetal hypertrophy, you can't use intersection technique. So what I do, I usually take the lateral border of pars, match with midline of TP, and wherever this line meets at the lateral border of facet, I take a bite of that facet and make the entry point. What about in thoracic spine? How will you make the entry point? So in T12 and T1, the entry point lies at the middle of transverse process or the mammillary body along the lateral border of superior articular process. As you go upwards up to T3, the entry point moves just above and medial, but don't go from medial to middle of superior articular process. At T1 and T2, it again moves lateral up to middle of transverse process and to lateral border of SAP. What I do between T3 and T10, I usually locate the lateral border of superior articular process and go 2 millimeter caudal and medial to that and make the entry point. Bite that process, bite that cortical bone and expose the cancellous mouth. Now you read, now I have to create my pathway in that tunnel, but there are a lot of angles described in articles, like you have to go 5 degree, 10 degree, 15 degree, 20 degrees. So how to get my trajectory right? For cordocephalate trajectory, you have to go perpendicular to lamina. If your lamina is this, you have to go like this. If your lamina is this, you have to go perpendicular to it. If you can't expose the lamina, just expose the transverse process and go perpendicular to it. And for mediolateral trajectory, just remember that at thoracolumbar area, the trajectory is moreover straight or slightly medially angulated. At the other levels, it is definitely more medially angulated, but you have to rely on your tactile feedback while getting this mediolateral trajectory. Use spinous process as a guide. Always try to aim medially and always gently insert probe. Don't apply any kind of force. Always a gentle rotation from 11 to 1 o'clock. If the entry is difficult, you can use ball tip probe to push the cancellous bone inside that tunnel. And once you get the past the tunnel and you insert your probe in the vertebral body is ready to take that probe. There are some peculiarities you have to remember about thoracic pedicle. That thoracic vertebra is a conical bone. High chances of lateral vertebral body breach are there, and the vital structure proximity make less margin, give you less margin of error. I personally use gear shift technique in my thoracic pedicle screws, where I use a curved Lenke probe. For the first 15 to 20 millimeter, I keep it stripped away from medial wall, and then after that I feel all my pedicle walls are intact, and then just take out and shift my gear towards the midline. Don't go like this. Don't do too much medial angulation. Always gear shift gradually. And there are two types of screws described in thoracic pedicle. One is surgical screw and another is anatomical screw. The entry point of anatomical screw is somewhat higher and the surgical screw is somewhat lower. The thoracic pedicle is not exactly perpendicular to the lamina, so it is somewhat caudally angulated. If you want to put anatomical screw, you will go somewhat caudal to that perpendicular line, and if you want to put surgical screw, then you have to go perpendicular to your lamina.
Tarun, can you summarize your lecture,
Yes,
please? We are already 2 minutes late.
So feel never let you down, but in some of the cases you see where your tactile feedback is not available. Thank you.